am Dr. Minter.
And I'm Nurse Bryan.
And this is Off the Cuff Nurses, where we talk about all things corrections and just whatever we want to talk about.
Right.
So today I thought that we would talk about charting.
Yes.
Because nobody likes to chart.
No, and it's very important. It's
Right.
huge.
Yeah. So we my friend who's a psychiatrist and we did a documentation lecture. I think it was for AANP, which is a nurse practitioner, big group. So anyway, we called it, or I don't remember where it was. And we said documentation because misery loves company. Mm-hmm. So, and we talked about why do we document? Because there's a lot of bad documentation.
There is. Unfortunately, you just find it.
Yeah. So, and there's certain ways to chart and there's certain ways not to chart.
Right.
So, and I'm not perfect. None of us are.
No, none of us are perfect, but we
but,
work on it all the time.
But I've certainly gotten a lot more careful charting over the years than I used to. So let's talk about charting. So when you're charting medically, there's templates for how to chart. And those templates exist as a guide. It doesn't mean that you have to follow them, but they're helpful in terms of laying out what you're going to do with a patient.
Right.
And how the patient presents. So one of the things that is used, or one of the templates is used, is called the SOAP note or SOAP E note. So SOAP stands for subjective, objective, assessment, plan, and then the E is usually, it's either evaluation or education.
Yeah, I usually use it as education.
Yeah, depending on who you ask,
Right.
on what day and what year and what place. So what does that mean? So the subjective is basically what the patient has told you. So, and I always like the subjective.
Me too. It's my favorite.
Yeah. So, and in corrections, it can be very colorful.
It's really, actually, I like reading people's SOAP notes
Right.
because of the subjective,
Yeah,
what exactly they said.
Right. Patient said, quote, F you, I'm not talking to you, and whatever the rest of it is. And you'll see that in quotation, but that's what they said.
Yeah.
So
I had a guy call me a black hyena. He's like, you black hyena. So I literally put that in there. He's like, F you, you black hyena. Because I was wearing all black. So every time he saw me, he's like, yo, black hyena, you. So anyways, yeah, subjective is my favorite as well.
yeah, so you can, I mean, I like to have a good subjective, so, because that paints the picture of what the patient is saying. So this is I'll say, so HPI, that's the history of present illness. So that's used more for a provider level, or you can say chief complaint. So I think you guys just use subjective.
Yeah.
Right?
Yeah.
So anyway, it's it may not be correct, but it's whatever they're telling you. So then you can compare it to what the actually objective says.
Right.
So the patient says, I haven't received my, quote, medication in the last 4 years because those nurses won't give it to me, whatever. I'm just making it
as
up.
an example.
Right. So the objective is what you see objectively, hopefully, in your exam. So it's, sometimes it's just talking to the patient. Sometimes it's a chart review, which people don't think about in terms of an objective. Objective can also be outside medical records. So whatever information you're gathering.
Right, vital signs, all that.
Right, all that is objective, right? Or, and I was just talking about medication adherence. Well, I can put down the bottom review of MAR, which is the medication administration record. Patient took 5 out of the last doses, 5 out of last 7 doses of, Acme aspirin or whatever he took, or has taken none of the medication. He is not taking anything. So that's an objective finding. Another thing that can be objective is pictures, which are great.
Yeah, I usually put a little note in there that I attached, an image to the patient's chart for reference. I usually put that in there.
Right.
Under the objective.
Correct. And measurements also within a picture. That's a good objective finding. I mean, I don't know who thought of the saying a picture says 1,000 words, but when you upload a picture, sometimes You don't have to say anything else.
Yeah. No.
And sometimes I'll say that in the chart. I'll say, refer to picture and chart. Mm-hmm. And the picture will pretty much say anything.
Oh, yeah.
So
it'll tell you everything.
Yeah. So, so objective is that, and then it's also the physical exam. The assessment is what do we think is going on with the patient? Mm-hmm. Now that varies a little bit from whether you're a provider or whether you're nursing staff. Mm-hmm. So I don't think you guys can actually make medical diagnoses.
No, we just use like nursing diagnosis, I guess you call it, or is that what it's called? Nursing diagnosis?
Yeah, I didn't do very well with that in school.
Yeah,
so back.
I don't really like it. I only have a few.
Made them up.
I pretty much have the few that I use, like, you know, impaired coping when they're like suicidal or something, or not dealing with something very well, or alteration in comfort because they're in pain, like kind of like that. I use like real simple ones, nothing that's complicated.
Right. So in terms of us, then I would just say COPD, acute exacerbation or whatever, mm-hmm. and then plus I could add a differential. Like if I think that this may be it, like maybe it's pneumonia, or I'll say rule out pneumonia, or possible pneumonia, or whatever else that I'm thinking about. And then in the plan is, what are you going to do about X problem?
Right.
Now, and then, so that's going to be different for you versus me. So my plan for if they have COPD is I might want to start them on steroids, might want to get a chest x-ray. I mean, I don't know, whatever. I'm just saying. Add an inhaler, whereas you might do a nursing protocol, mm-hmm. right?
Yep, a nursing protocol, or I can put on there that I spoke with, APRN so-and-so, orders received to start da-da-da, whatever it may be, mm-hmm. And then I go ahead and implement those orders and put them in the chart and get it started.
Right. Sometimes you can put a quick note in, but the problem, or a brief summary note, but the problem is it's not set up where it's bulleted like a soap note.
It walks you through like exactly what you need to do. I think for me, this is what I do. So when I'm in booking and I need to do a quick note, I usually put pretty much everything I would put in a soap note, except for sometimes I have to leave out subjective because the patient will not speak with me. They may be uncooperative and they're like, put their head like this, and I'll ask them a question, then they won't answer. So I can't really, I'll start a soap note and I go, oh crap, I can't really put a soap note because I can't put anything subjective wise. So I'll go ahead and just do a quick note, but I'll put the rest of the objective assessment plan and education, I'll put that all in there, but I'll leave out that part.
Right.
So that's when I'll choose to do a quick note over a soap note.
Yeah. And some places don't even have that because they're still manual.
Mm-hmm.
They're still writing stuff.
Right.
And then there's plan, like I said, which is, well, I mentioned it, is plan is, so what you're going to do about with the patient, and then either evaluation or education. Mm-hmm. So the education portion is pretty important because you want to say, if you're having any worsening symptoms,
correct,
you got to tell somebody,
mm-hmm.
or whatever. Or if you have any side effects of this medication that we're prescribing you, please notify us. Mm-hmm. Patient was educated on side effects, whatever. So that's a SOAP note. Mm-hmm. So then we don't use that SBAR as much. Mm-hmm. I mean, I don't, but so explain what an SBAR is.
So SBAR is a good tool for when you are calling a provider, especially someone who's maybe not on site or they're in a different location. You're giving the situation, what's going on at hand with the patient. You're giving the background on the patient, maybe their history. You're doing your own assessment. So whatever your assessment came out to be, whether it's heart sounds, lung sounds, and then you're doing the recommendation aspect, which I think as a new nurse, sometimes that is kind of hard to do recommendation.
Correct.
So that's something that a lot of people have to work on. But the SBAR is a good tool, like I said, to set you up to when you talk to the provider, you don't sound like you're all over the place. You know what I mean? You have like a nice layout for the provider, because sometimes they might be sleeping at home and you're waking them up and you're like, hey. And so by giving all that information, they can pretty much make a good, recommendation or plan for the patient based off of that.
Well, I think that you're right about the new nurses. So in terms of recommendation, I think that there's a misnomer that means that you're telling the provider what they should do. Mm-hmm. But that's not really what it means.
Mm-mm. I usually, for mine, I'll ask them and say, hey, do you want to, I'll suggest something, and they can tell me no. I don't care. They're the one making the decision. But I'll say, hey, do you want to start this, or do you want to do that? Do you want to go ahead and give a neb treatment, see how they do? Something like that. Whether if it's a protocol, then you can do the neb treatment on your own. Or you can just say, hey, I did a neb treatment per protocol. They're not responding well to it, or something like that.
So explain what a protocol is.
So a protocol would be something that you would implement without having to call or contact the provider initially, unless things, get worse or don't improve.
How?
So for where I work, we have nursing protocols for chest pain. We have nursing protocols for patient with shortness of breath. And like, for instance, like the shortness of breath, some places may say, okay, before you contact the provider, listen to lung sounds, get their vital signs. If, they're coughing and they can't seem to stop, you may give a albuterol like nebulizer treatment. Some places say you can do it once, twice. I mean, this is just an example. Everywhere's different. And sometimes you'll just give like one nebulizer treatment and the patient stops coughing and they're fine. So, you won't even need to contact the provider. This is just like standing orders pretty much at the end. So it kind of lays it out for you like, kind of like the SOAP note, except for the plan would be whatever the nursing protocol says to do for that specific, problem the patient's having. So
It doesn't cover everything.
No, it doesn't cover everything. Some things aren't even on there, but, like the popular stuff, I don't know, like chest pain, shortness of breath. I'm trying to think, just regular pain. They might have something that says like, as long as they don't have allergies to the medications, they can start either A or B, Tylenol, ibuprofen, something like that. And if it persists, it may even say, if the patient continues to experience pain, place them on sick call, for the MD for the next day or whatever. It's like a suggestion basically on there of what to do. And, it kind of covers you too by doing these things, because like you're doing it the right way. This is like the protocol. If, like you said, if something's abnormal and it's not under the protocol, you'd call the provider with that SBAR, So, but like I said, some nurses use it, some don't.
Well, I think there's nursing. It's difficult. You got to, especially if you're newer, walk the line as to, and where you work. What do you call about versus what do you don't call about?
Right.
And what do you call about immediately or what can wait?
Right.
So, and I think that's probably one of the hardest things for a new nurse to.
Yeah.
Yeah,
it's true. No, it is. It's like, some nurses, I don't want to call it common sense, but I think it's more of something that you learn with time and it gets drilled in your head, like where you're like, okay, this can wait. This is immediate. This is urgent, so, but some people don't have that. So I don't know. I've worked with some nurses that are quick, and some of them are the LPNs. Like they've been an LPN for, 20 plus years. And, sometimes they're giving the RNs pointers on things because they might not be so quick to realize what's urgent or not. Even though it may come off as common sense, but some people, it might, they worry too much to cover themselves. So they question it. Right.
So you walk the line about kind of burning out your providers versus, with repetitive phone calls versus has everything been done?
Right.
And I don't mean anything that's, obviously you got CPR going and you need to call somebody,
Yeah, of course.
but chest pain is a common occurrence in corrections. And some jails just don't have the infrastructure of nursing that some of the bigger jails have.
Right.
Like they may not even have any medical providers on site more than maybe once a week.
Yeah, and depending on where they work, they may not even have protocols. Like they may just have to like wing it, which is really scary too.
Right, but it's possible.
Right, it is possible.
So, and anyway, it just depends where you work, who you're working for, what your electronic medical record is, and how that's set up. Because that's the other thing is that your electronic medical record they're not all created equal.
Yeah.
So you may have a good one that has protocols within it. You also may have templates that are where you could just put in whatever is applicable to the patient and hopefully change it. If you don't change it and somebody looks at it, like a lawyer looks at it later on and says, okay, well, you've got, you're putting a pelvic exam in and you're charting on a male, right?
Right.
Saying normal, cervical, whatever. I mean, come on. So
I've seen that. I've
seen
where
it
doctors
too.
will put like pregnancy test positive and it's a male.
Yeah.
But I think it's because they, that's why they say no, don't copy paste because, they copy and they'll paste to the next patient. But like you said, if they have like a template laid out, it might be easier for them.
Right. Well, you got to be careful with templates.
Yeah.
And you got to make sure that you change what's applicable in there.
To the patient, yeah.
I have some templates that I use, and it forces me, the way I have it set up, that I have to actually go in and actually answer the questions versus just have it come in and the question's already answered.
Right.
If you understand what I'm saying. So like a head injury, they'll say loss of consciousness. Instead of saying with a colon, yes, it'll say yes/no. So it actually forces me to come in and back pedal that no or yes out.
Right.
So it hopefully kind of minimizes. There's always mistakes, but somewhat minimizes the mistakes.
Right.
So
I know some nurses will only document, like, I don't want to say the good stuff, but just like very basic things, and may leave out things. And they think that, I've heard from people that if, they document something bad, then they're liable for whatever happens to them afterwards with whatever condition it may be, you know? So that's kind of scary, is like, in nursing school, they talk about how you need to paint a picture. I mean, they say that when you document that, it should be so well written that you pretty much can like be sitting there next to this patient that they're talking about, if that makes any sense here. So it's like, instead of being so like plain, you'll say, like, for instance, like you have a 64-year-old black male with a history of blah, 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 and you really paint that picture. They're sitting upright in their chair, or are they hunched over? Like, you really try to paint that for them to give a good picture, because people change so rapidly too. Mm-hmm. So. Well,
not only that, the other thing is don't chart 5 days later.
Yeah, that's bad. That's really bad.
I mean, that's kind of, you can do it, but I mean, too many late notes, because it's usually time stamped. And again,
all of that.
Yeah, I mean, it depends on the EMR, but again, I think when you write the note, it's time stamped when you wrote the note. So either say, I saw this patient at this time,
right,
on this day, or whatever, but hopefully you do it. That's what I tried to do, notes right then, right afterwards. It's just,
I think that's the goal, is like you want to chart in real time, but when you don't have a laptop or next to you, like it's not usually like right in your hand as you're providing patient care. So you try to do it as close to the time that you saw them as possible, but it's super important to put in there that you saw the patient at a certain time or approximately a certain time, because like I said, they do change so rapidly. Because, at least in booking, I may document that the patient was cooperative and in no acute distress, and literally 2 minutes later, uncooperative, will not talk to anybody, thrashing around. So that's why, like you said, it's important to make sure that you have that time in there.
Right.
Because you don't want to look like you're crazy, like, wait a minute, how is that possible? But you want to document as close to the time as possible.
Yeah. I mean, I've seen charts that are, in the community, it's not even in corrections, where it's been added much later. And I always kind of wonder about that.
Yeah.
And then again, it's templates that have been obviously pulled in.
Well, it's suspicious. I think if you're looking out from the outside in, and you have a nurse that may have wrote an addendum, like you said, 5 days later, that's kind of suspicious. It makes you think that they found something that they have to cover themselves for. That's why you need to do it that shift. You need to go ahead and chart whatever you saw or whatever the encounter was.
Right.
Yeah.
And one of the things you can do that I do is have somebody else read it. Before you hit send, say, does this make sense?
Yeah.
And is this coming off unbiased?
Right.
Because you don't want to come off like, that the patient's kind of in a bad light. And that doesn't mean that the patient isn't malingering or whatever else, but there is usually some sort of element of truth where something is going on.
Right.
So have somebody else read the note and say, what do you think about this note? And it doesn't have to be, another provider. If you're an NP or an MD, you can get a nurse or just another pair of eyes to look at it. So that's my other suggestion.
Yeah, and depending on where you work, like some places may have like the one nurse of all the nurses that attended a code do the main note. And so I think it's important to have maybe another nurse that was involved in it and read your note to see if that sounds all right, you know?
Correct.
Or if you missed anything. Hey, did I miss anything that we did? Yeah.
And the other thing you can do is in corrections is go back and look at the cameras.
I know, I like that. It's it's good and it's bad, but it's most of the time it's good because you can see what happened during a code or some kind of medical event, or especially I think that's important with the head injuries, you know, to see the mechanism of injury. Like, did they really hit their head or did they not? Yeah, because they may say, you know, I hit my head, but then we can look back and see if they actually did.
Right, and they can slow it down too.
Yep.
So you can see when they're falling, like, do they put their arm out or not?
To catch or whatever.
Right.
Yeah.
And I actually document the camera number and the time. So I'll put, you know, whatever, you know, 2218 at, you know, 10 a.m. or whatever it is.
Observe patient, you know, catching fall or whatever.
Right.
Maybe.
So they can go exactly back to the camera that I looked at that time and say, okay, this is how she came to her conclusion.
Right.
So anyway, so those are some of the pearls for notes and documentation, which is so important.
It is.
And maybe we'll do a little bit more on that another time.
Yes.
So
there's a lot to it.
but maybe not today. So anyway, I am Dr. Minter.
And I'm Nurse Bryan.
And this is Off the Cuff Nurses. We will see you next time.